We do have time now for a panel discussion and questions from the floor, and it'd be great if you could, as the panel come up, so Rory and Paul and Jonathan, back up please, to take questions about the imaging project in general, comments, questions about the incidental findings protocol, if you have them, or indeed anything else that springs to mind.
Cathie, can I just kick off and ask you actually, in terms of the guidance that the radiographers get and also the guidance that the radiologists get, I mean, the radiographers are being trained very carefully in the things that are considered important, and the radiologists also are being told what things should be reported. Do you want to expand on that?
Yeah, so we went through a very careful exercise, which was actually very much based on an exercise that had been gone through by the German National Cohort, who have also been planning a very large-scale multimodal imaging study, to think about, first of all, what we might expect the frequency of incidental findings to be based on the literature. And as Jonathan said, there's not a great deal of literature outside of the brain, but from what we could gather, based on largely radiology reporting, we expected maybe between 10 and 15% of our participants to throw up something that might be considered potentially serious. We knew that some of those would be false positives, particularly from the body fat scan, because in non-technical, non-imaging researcher language, the pictures are a bit fuzzy-wuzzy, and you see sort of blobs and lumps and things, and it's a bit difficult to know whether they might be something like a tumour or whether they might just be some artefact or something that doesn't really matter. We provided then, we generated a list based on the work that the German National Cohort investigators have already done, of the types of findings that we would consider to fulfill our definition of potentially serious. And we were very careful about trying to create a definition that was comprehensible, but also would cover the different modalities reasonably well. And then that list has been provided both to the radiologists and to the radiographers. And the lead radiographer based in the imaging centre in Manchester has helped her team of radiographers to understand what that means in radiographer language. And our team of radiologists have also discussed that list with us and have tweaked it a little bit. The radiographers are trained primarily to acquire the images for research, and they spend a lot of time doing that. They are not doing a systematic diagnostic review of the scans in any sense, and it's made very clear to the participants that that is not what we're doing. We're acquiring scans for research purposes. But they do know the types of things that we would want them, if they spotted them, to escalate for subsequent review by radiologists. But this... knowing what radiographers are likely to spot, there is some anecdotal experience out there, but there's really very little published. So I think we'll generate some useful data on that in itself, and also on what proportion of those findings do turn out to be false positives in terms of potentially serious. It cannot be that 17% of the UK Biobank participants, who are on average about twice as healthy as UK individuals of the same age, have 17% of them harbouring potentially serious findings that fulfill that definition. So this must be to do with the nature of imaging, and others can comment on that as well.
Can I just comment, Cathie? I think there are two other points that, of course, the data thus far is limited, and there are big training effects in this, and they work in big training effects on the frequency with which someone will identify a possibly serious abnormality. And I think both the radiographers and the radiologists are learning in this short period that things have been going on. So I think these figures have to be taken with some caution. I think the second thing that is important to appreciate in considering that is that radiologists are trained in a clinical diagnostic setting where the prior probability of disease is high. And this is now operating in a setting where the prior probability of disease is very low. And it really is it's a fundamental shift of mindset. And so what we expect is that there's going to be an enormous amount of learning that will occur during this year on an individual level as well as at the level of the study.
Yeah.
I understand that the 12 EDCGs will be undertaken at the same time as the imaging study, and I wonder if you have the same sort of protocol in place for identifying, well, abnormalities or variations of normality, because that's a big problem we deal with routinely in cardiology.
Do you want to comment on that, Rory?
Yeah, I mean, actually, with respect to the 12-lead ECG, it's going into a black box. So it's not being fed back.
Ben Shlem, University of Bristol. One comment and one question. You said that to get feedback on whether people understood the consent, you were doing some questionnaires, and the comment would be, there's really good data showing you must do qualitative research if you really want to understand what people understand by PIS. That's a suggestion. But the question was, as Paul said, this is supposed to be a low prior risk population. Though I do wonder how many people might accept the invitation because they've got a concern and they have symptoms. So my question was, if they come to the clinic and they tell the radiographer, well, actually, yeah, I've been getting a headache for the last week every morning when I wake up. So now actually they're not asymptomatic, they are symptomatic. How do you handle that in your protocol?
Just to address the first question, in my effort to be brief, I was probably a little bit too brief, and to say that we are indeed conducting some qualitative research with some social scientists as well. So we clearly realise the value of that. And in terms of the...
In terms of the going through the imaging, people go through the imaging on the understanding there'll be no feedback. So information is recorded. When the radiologist does the review for the first 1,000, they can look at information that's recorded in the visit, but we're not part of a diagnostic service. It's on the basis there will be no feedback.
But do they, when they look at the image, because they are looking at the image, presumably if the person does tell them something of clinical relevance, they will incorporate that, or will they ignore that?
If information's recorded as part of the assessment visit, then they can look at that. But if it's ad hoc information, it may well not be in the system that they can look at.
So actually the quality of the clinical information is much more consistent than it would be for your average hospital junior doctor radiology request, in that it's systematically the same data on age, gender, past medical history and medications, and some smoking, alcohol history and BMI and things like that are provided to the radiologist. We did wonder about whether that was the right thing to do or not, but in the end we thought that it would probably help to contextualize the reporting in a systematic way.
But actually, another point is that I mean, on the day of the scan, this process is moving pretty briskly. So it's a little bit unlike a hospital where there'd be a lot of waiting and conversation. The radiographers and the subjects won't necessarily. I mean, I can imagine it could happen, but I would have thought the scenario that you outlined was somewhat unlikely.
I think we've time for one more. Yes, Barbara.
Yes, it's a question, Barbara Casadei, Oxford. It's a question to Paul Matthews. It is really regarding the cost of the analysis of the images, right? So for the first investigators that want to use this resource, it would be quite expensive to factor in the analysis of the images. You mentioned crowdsourcing, you mentioned generosity. So I was wondering whether there was any plan by which these images could be put out in the public domain, and the College of Radiology being asked, why don't you, out of your generosity, in the same way that there is Galaxy Zoo, right, where people are classifying galaxy all over the world, whether there could be a similar process by which these images are analyzed in this way, or at least some of them, or for the most simple parameters.
Well, I'll give you my idiosyncratic answers, and not as a radiologist. Radiologists read an image. What we're interested in most of the time in this context is quantitative data, which is something that radiologists don't usually concern themselves with. Now, your point about crowdsourcing is absolutely central to the way this is designed. So what we're anticipating, and in fact what we're already seeing, is that imaging researchers around the world are expressing huge enthusiasm for this project, and they can't wait to get their hands on the data in order to turn it into information. And each has a different approach, and all of the approaches can work together because it's a non-depletable resource. What we anticipate seeing is that all of these analytical approaches will feed into a database of derived data sitting with Biobank that will enrich the epidemiology community and, in fact, also stimulate new kinds of imaging analysis research. A very specific example, that I think you'll understand very well, is how difficult it is right now to get quantitative cardiac imaging data quickly, because it's a very painstaking semi-manual process. There is no reason that can't be solved in the current century. And so that's certainly something that the Cardiac Brain Atlas folk in Australia, the US, and here are terribly excited about doing. That work is starting already for all modalities, and I think we're going to see a new kind of revolution in the approach to this data, just as we saw with ADNI, the Alzheimer's Disease Neuroimaging Initiative in the US over the last 5 years.
Thank you.
Okay, thank you very much indeed for questions and for contributions from the panel.